All right, good morning, everyone. My name is Megan King, and I use she, her pronouns. I'm one of the organizers from the Washington Poison Center for this series. Before I turn the session over to Dr. Kaiser, I have a few housekeeping items to go through. This session is being recorded. We will make all recordings and slides available by early next week. In order to earn a certificate of attendance, you must watch a minimum of 5 live or recorded sessions by September 15th. And as a reminder, we're not able to provide CEs or CEUs this year, just that certificate of attendance. Please ask your questions in the Q&A tab on the right-hand side of the screen in Whova. If you're watching through Zoom, we do have chat enabled, so you should be able to enter your questions there. Dr. Kaiser will answer questions at the end, but please pop them into that Q&A tab or chat as you think of them. And you're welcome to also introduce yourselves and chat with your fellow attendees in that chat tab. So that is it for housekeeping. Now I get the pleasure of introducing our speaker, Dr. Sasha Kaiser. Dr. Kaiser is our Associate Medical Director at the Washington Poison Center. She completed residency training in emergency medicine at Denver Health and Hospital Authority and a fellowship in medical toxicology at the Rocky Mountain Poison and Drug Safety. Dr. Kaiser will be talking to us today about herbal abortifacients. This topic it's a shift from what we've traditionally discussed during this series. We felt it was very important, though, to bring this into our discussions as legal and public discourse around body autonomy for women and others with uteruses evolves on what seems like a daily basis. So Dr. Kaiser, thank you for diving into this controversial, emotional topic with us. I will turn it over to you now. Thanks.
Wonderful. Well, thank you everyone for showing up in the morning time and hanging out with me as we go through this. I'm going to go ahead and share my screen. Fun. Megan, does it look like our
presentation? Looks great.
Perfect. Well, good morning. My name is Sasha Kaiser. As Megan had mentioned, I'm a medical toxicologist and emergency medicine physician. In a world where conversations about reproductive health choices are increasingly taking center stage, it is imperative that we create a space where diverse perspectives can be shared and understood. The use of herbal substances for inducing abortion is a topic that spans centuries and cultures, touching on aspects of personal agency, medical ethics, legal framework, and socioeconomic factors. Throughout history, communities around the globe have turned to herbal remedies as a means of addressing various health concerns, including pregnancy termination. And these practices often reflect cultural beliefs, access to medical care, and the limitations imposed by legal and social constraints. I'd like to emphasize that the intention of today's discussion is not to endorse any particular viewpoint. This is not political. However, we will delve into the political perspectives of abortion and pregnancy in history. The views discussions are my own and do not represent the Washington Poison Center. The objective of this talk is to provide insight into the medicinal abortion over time so that we can really understand the impact on our current environment. At the end of the talk, what I really want to make sure that we touch on is reviewing the history of this, reviewing what is our current modern medical abortion regimen, and really discussing some of the basic pharmacologic properties of a couple of herbal abortifacients, looking at the safety and risks associated with these. In order to start this off, we really need to touch base on our terms. So abortifacient is a term derived from Latin roots with abortus meaning miscarriage and faciens meaning making. It's a non-specific term that refers to any substance, plant, herb, or prescription medicine that affects gestation to induce abortion. A menagogue is a Greek term that mena meaning menses, a gog, leader, or bringer. It really describes substances that stimulate or increase menstrual flow. Typically refers to herbs recommended for uses in delayed menstrual bleeding, even when pregnancy is not the direct cause. Blocked menses was seen as a problem in humoral medicine in the past, and just like other types of bodily blockages, bowels, for instance, required unblocking. A regular period was really considered necessary to have a monthly expulsion of these evil humors, and so additionally, since these medieval times, it's been used as a euphemism for inducing abortions. There is some overlap with the term abortifacients, as all abortifacients are amenagogues, but not all amenagogues are abortifacients. This is not a new topic. The Ebers Papyrus is one of the main sources of our knowledge about ancient Egyptian medicine. This was suggested to be written around 1550 before Common Era, or 3,500 years ago, and it contains more than 800 remedies for ailments ranging from baldness to liver disease to crocodile bites. Papyrus includes a long section on the remedies one prepares for women, with 70 entries on treating conditions like breast disease, irregular menstruation, uterine prolapse. The section begins with instructions on how to induce abortion using a plant fiber tampon coated with a compound containing honey and crushed dates in the first, second, or third period of pregnancy. As described, the use of herbal abortifacients dates back centuries and was a common practice prior to the development of modern medical techniques. Historical use varied across cultures and regions, often influenced by regional cultural beliefs, available plant resources, and societal attitudes towards pregnancy and contraception. Prior to modern times, reproduction was associated with high mortality risk. Knowledge on misreproduction was really essential for survival. Some scholars point to the gender specialization that was cultivated in the Neolithic or Stone Age. During this time period, humankind saw a transition to the development of settled agriculture, animal domestication, and the use of tools. While men would be off on hunting expeditions, the women would focus on foraging. And women really acquired an expertise in seed and vegetation cultivation, which resulted in more reliable sustenance for their communities, but also a greater understanding of plant medicinal properties that men were typically not privy to. This exposure and understanding offered opportunities for women to use this proficiency to control their reproductive lives. Herbal knowledge was often passed down through oral traditions, written manuscripts. Ancient civilizations such as the Greeks and Romans documented the use of various plant-based remedies for fertility control and abortion. Ancient texts and records contain references to herbs like pennyroyal, tansy, silphium, which were believed to have abortifacient properties. The Lakota ingested Western sagewort or the outer bark of the black elm to end unwanted pregnancies. The Shoshone and Navajo drank an infusion of stone seed, whose name in Crow means miscarriage, plant, or abortion. A medical compendium from ancient China called the Shennan Banqua Jing, written between 206 and 220 AD, listed the properties of 365 medicinals, 5 of which were noted to stimulate abortion. Common methods during that time included teas, infusions, intravaginal applications, and more surgical techniques such as catheter abortions and DNCs or dilatation and curettage. As we move through history, there's an increasing focus on reproductive health. In colonial America, over her lifetime, the American wife bore an average of 8 children, and thereby doubled the colonial population every 20 years. In the early 1800s, the stakes were high. It was estimated that 500 in every 100,000 births ended in the death of the mother. In the late 18th century and early 19th century, many American homes would have a copy of Domestic Medicine by William Buchan, pictured here. And this book included instructions on how to eliminate obstructive menses, which was another euphemism for early pregnancy. Additionally, around the same time period, we started to see pills surface that were advertised to assist in female irregularities. These pills contain substances such as turpentine, tansy, pennyroyal, and like most medicines during this time, were not highly regulated. While this could result in pregnancy termination, it could also result in maternal death. Culturally, pregnancy was viewed differently. Prior to ultrasounds and fetal heart tones, human life or ensoulment was in most cultures began at the time of quickening, or when a pregnant woman first feels fetal movements. It was usually attributed to about 16 to 24 weeks of pregnancy. For most of history, ending a pregnancy prior to quickening did not have the modern legal or political restrictions and taboos. Early medieval laws did not discuss abortion prior to quickening, and women who took drugs before the quickening would describe their actions as restoring the menses or bringing on a period. In English law, abortion did not become illegal until 1803, and most of the first laws were really more focused on medicinal abortions, not mechanical ones. Medicinal abortions were also more likely to be administered by women, given kind of that oral tradition and handing down of the discussion of herbs. In 1857, a political campaign started with a paper called On Criminal Abortion in America. In this, the committee argued that abortion was a criminal and immoral act in the vast majority of cases, except in rare instances when the life of a pregnant woman was at stake and could not be saved by any other medical intervention. This campaign really aimed to sway public opinion that life must begin at conception rather than at quickening. The article argued that the fetus could not be considered dead before quickening and therefore must be considered alive, and that abortion was murder because it involved willingly terminating a life in its early stage of existence. This campaign was highly effective. Between 1860 and 1880, more than 40 anti-abortion statutes were written into state and territorial law codes. Campaign had significant political implications. The main crusaders really argued they were advocating for women's rights, but for some women, it was just seen as a decline in power and status, as women described a loss of right to choose, a sentiment that would carry on and lead to future controversy in the 1930s. As mentioned prior, in the late 1800s to early 1900s, there were some viewed loopholes, however, when a woman's life was viewed to be in peril. This resulted in variable interpretation of some of the laws, and some providers would still be willing to perform abortion. This is an example from the 1950s of some indications and codes for therapeutic interventions, including but not limited to if the mother was pregnant, if the mother had cancer, epilepsy, severe mental health disease, or tuberculosis, rheumatic heart disease, were some of the ones where it was deemed appropriate in some situations to consider a therapeutic abortion. In 1959, the American Law Institute, which is an assembly of experts responsible for crafting model legislation, proposed the relaxation of abortion laws. Their recommendations include provisions for situations such as rape, fetal deformity, and threats to mental or physical health. This movement towards abortion reform was underpinned by the broader societal transformation in American perspectives on reproduction and abortion. In 1964 to 65, a rubella epidemic swept through the United States and caused widespread panic among every pregnant woman in the country. Rubella, which is also known as German measles, is a disease we hardly think about anymore, but it's the R in the MMR vaccine. The 1960s was prior to that vaccine, and there was a paucity of really reliable diagnostic testing. There was also no real way to prevent yourself from getting it. And if you wound up having a baby with congenital rubella syndrome, there was very limited support. The American with Disability Act was not signed until 1990, and at this time there was no social support of any kind for people with disabilities. Though the rubella virus is relatively harmless for most people, maternal viral infection during pregnancy, especially during the first 3 months, has the potential for reducing the number of fetal deformities and harm. An estimated 20,000 to 30,000 children were born with congenital rubella syndrome as a result of the 1964 through 65 rubella epidemic in the United States. There is a NBC News archive from 1969, which lists crippling abnormalities, bad sight and hearing, heart disease, mental retardation. At least 20,000 other babies were stillborn. Rubella epidemic comes in cycles 6 to 9 years apart, and most authorities expect the next epidemic to come in the spring of 1971. And as you can dissipate, there was worldwide panic knowing that this was there and knowing that there wasn't much they could do about it. Additionally, during this time period, thalidomide was marketed internationally to pregnant women in the late 1950s and early 1960s as a treatment for morning sickness. Infant mortality in babies born with severe thalidomide embryopathy was as high as 40%, quite likely due to the internal organ damage. But then there also began to have photos circulating in media showing babies with phocomelia, or absent deformed limbs, which heightened the concerns for maternal exposures and continued to really spark a conversation of who gets to choose the exceptions for legalizing abortion. And then 1973 happened, which was Roe versus Wade. Roe versus Wade had 2 key parts. First, the court ruled that before viability, it's a pregnant person's decision, not the government's, whether to continue pregnancy. Accordingly, the government cannot ban abortion for any reason prior to viability. Second, Roe held that, as with other fundamental rights, restriction on the right to abortion was subject to strict scrutiny, the most stringent level of constitutional review. Roe permitted more regulation of abortion as pregnancy advanced, but only when the regulation was evidence-based and consistent with how other similar medical procedures were treated. At the time that Roe was decided in 1973, nearly all states banned abortion, except in certain limited circumstances. The Roe decision made state abortion bans prior to viability unconstitutional, and the abortion care legal, thus increasing access to safer approach. After the point of viability, the states could ban abortions or take other steps to promote its interest in protecting the fetus. But even after that point, the abortion must be permitted to protect a patient's life and health. In recognizing the right to abortion, Roe was really consistent with earlier Supreme Court rulings recognizing the right to privacy that protect the intimate and personal decisions. So around this time period, the CDC began to do some surveillance looking at abortions over time in the United States. Starting in 1969, they started to document the number and characteristics of women obtaining legally induced abortions. These were voluntary reports. Not all states participated in them, but what their aim was really used in the interest of public health. They wanted to evaluate the success of programs that promoting equitable access to patient-centered quality contraceptive services in the United States to reduce unintended pregnancies. They wanted to calculate pregnancy rates on the basis of number of pregnancies ending in abortion in conjunction with birth data and pregnancy loss estimates. Monitor change in clinical practice patterns related to abortion, such as changes in the types of procedures used, and calculate the national legally induced abortion case fatality rate. The thing that I want to point out with this is the change of this over time. So again, 1973 was when we had Roe versus Wade. And as you can see right here, there were more legal abortions reported during this time period. But the big thing that I want to point out is the difference with case fatality rate. This was significantly higher. And this continued to downtrend as more options became available and two, as our medicine improved. The other thing that they started to look at, in addition to this, is they looked at the type of abortions that were being performed and at what time in gestation. As we can see here, the primary number of abortions were performed in the first trimester. And of those, the majority of them were medical. The surgical ones tended to have a little bit move into the later time periods as well too, but these are still really big numbers. This right here looked at it over time, and what you can see that I want to point out is for your females that are age 25 to greater than 40, they had increased rates of medical abortions over that time period. So all of these showed a positive increase with how many abortions were being utilized. So how do these work? Well, in the legal medical abortions that we have now, there's a couple different ways that this is processed. Implantation of a fertilized ovum involves complex interaction with the endometrium. The embryo becomes attached to the endometrial epithelium and invades the endometrial stroma on day 6 to 10 after ovulation. These events really depend on progesterone, which modifies the implantation process. Progesterone also inhibits the myometrial contractions. So the drugs used to terminate pregnancy act by inhibiting the synthesis of progesterone. They also can act by producing oxytocin-like activity, resulting in uterine irritation and contraction. They can inhibit the development of the trophoblast. They can also flush the zygote from the fallopian tube, block the uterine horn, which inhibits the implantation, induce fetal resorption, or indirectly affect pregnancy by altering hormonal concentrations. The medication abortion regimen supported by major medical organizations nationally and internationally includes two medications mainly, mifepristone and misoprostol. If misoprostol is unavailable, then sometimes they'll use misoprostol only. However, it has significantly decreased efficacy, and so they're usually used as a combination product. Mifepristone is a selective progesterone receptor modulator. It binds to the progesterone receptor with an affinity greater than progesterone itself, but doesn't activate the receptor, thereby acting as an antiprogesterone. Mifepristone's known action on the uterus during pregnancy include testicular necrosis, cervical ripening, and increased uterine contractility and prostaglandin sensitivity. Misoprostol is a prostaglandin analog that causes cervical softening and uterine contractions. Methotrexate is another agent that comes up as well. It's not one of the first-line recommendations for medical abortions, but it has been used in the past with a mechanism that focuses on inhibiting trophoblast division. This is an example of the regimens that are in place right now that have been approved by the FDA and by bigger organizations such as the American College of Gynecologists. As you can see here, less than 9 weeks, you start with the mifepristone and then you add misoprostol within 24 to 48 hours. And before 10 weeks has about a 96.7% efficacy. Similarly, once you start to get above that, you may need some additional agents of misoprostol. But what you're going to see is that it's a very similar regimen with similar efficacy. Once you get greater than 12 weeks, that efficacy does decrease, but this is still an option in some situations where they consider to do this. At this point, too, the question starts to become about more surgical options for this, but there are some subset of patients that you can continue to use this. It just means adding more misoprostol doses to increase that efficacy and get closer to the 94 to 95%. As we mentioned before, mifepristone, also known as RU486 or Mifeprex, is a steroidal antiprogesterone, antiglucocorticoid, and antiandrogen. Acts as kind of a competitive progesterone receptor antagonist. Causes decidual degeneration, cervical softening, dilatation, release of endogenous prostaglandins, and increasing the sensitivity of the myometrium to the contractile effects of prostaglandin. It was first recognized in 1982 when they initially used it by itself, had a success rate between 64 to 85%, which was really not adequate for general clinical use. But when they started to add a prostaglandin, they found that those went up to the mid 90s to high 90s. The most severe side effect of the regimen of mifepristone combined with a prostaglandin is excessive vaginal bleeding. Nevertheless, when used as directed, blood transfusions are rarely needed. In a systematic review, only 38 of 25,907 women, or 0.1% in the studies summarized, received transfusions. In one study, the mean fall in hemoglobin concentration was 0.7 grams per deciliter, and less than 8% of women had a reduction in hemoglobin that exceeded 2 grams per deciliter. The volume of blood loss is a little bit higher than with surgical abortions. In patients who were using this regimen, what they found is that their average blood loss ranged from 84 to 101 milliliters compared to a mean loss of 53 milliliters in women undergoing surgical abortion, but again, did not result in clinically significant changes. The one thing that they did find with some of these studies is that women tended to have some that bled for longer. So in one study, you had mild bleeding that persisted for more than 30 days in 9% of women, and for another study, more than 60 days in 1%. Because of this prolonged bleeding, one of the perception among women was that the bleeding was more pronounced after medical abortion than after surgical. But what they found is that, again, the amount of blood actually lost that required intervention was insignificant. The other thing that's important about this is all of these agents you think about with your therapeutic, but you also think about this in overdose as well too, if they take too much because they don't know how to take it, because there is not direct guidance by a medical professional. So some of the limitations with that is, in addition to the vaginal bleeding, it also has the ability to inhibit the pituitary adrenal axis and inhibit the ACTH inhibitory activity, which can result in adrenal failure following massive doses. Additionally, this can have hypercortisolism, Cushing syndrome. It can have some episodes where you have hypokalemia, but you can also have prolonged QT. And so this is something that has to be considered carefully in patients who are on other QT prolonging agents. Treatment is primarily supportive. If these patients are having hemorrhage or significant blood loss, then you look at managing those with blood transfusions, supporting their volume status, and then keeping an eye out for adrenal failure as well, which again is unlikely, but in really, really massive overdoses has been shown to happen. Misoprostol, also known as Cytotec, is the synthetic prostaglandin analog. Again, causes uterine contractions, ripening of the cervix, and as with a lot of other agents, their effects and toxicity are really an extension of their therapeutic features. You can see abdominal pain, vomiting, diarrhea, headaches, dizziness, uterine contractions, and bleeding. Rarely you can see hyperthermia, rhabdomyolysis, acute kidney injury, transaminitis, metabolic acidosis, and GI tract bleeding. Treatment, again, is primarily supportive care, managing your hypovolemic state, especially if you're having a lot of GI losses, and then managing if there's any concerns for hemorrhage. Methotrexate has fallen out of favor as there's more efficacious treatment regimens with increased safety. It has been used in the past in less than 9 weeks gestation. It does have increased efficacy when you add misoprostol into it. There are multiple different dosing strategies that are available for management with this. And really, what you are thinking about with this is ultimately antimetabolites such as methotrexate inhibit your DNA synthesis in rapidly dividing cells, such as the trophoblast, resulting in release of prostaglandin and cytokines, extravasation of blood into the uterine contractions, and expulsions of embryonic or fetal tissue. At oral doses less than what you would be using in medicinal abortions, the absorption is around 90%. And as you get that a little bit higher, there is some satural absorption as well too. Acute overdoses tend to be a lot more favorable than more chronic cases. And so these are ones that can be managed pretty well. In really severe cases, you can see patients who will have stomatitis, mucositis, esophagitis, kidney failure, myelosuppression, hepatitis, and CNS dysfunction. This is not something that we would usually expect if it's being used as a medicinal abortion, but it is something that is possible if somebody's using this incorrectly or doesn't understand how to use it, especially if they're accessing non-medical providers to obtain this medicine. If you have a patient who's coming in with this, a lot of this again is going to be supportive care. Initially, in acute situations, you're going to see more of the GI features. In really severe cases, you may consider folinic acid or leucovorin, but this is less likely in just an acute overdose situation, especially given the fact that there is some saturable kinetics with your PO administration. So that was our background. And then on Friday, June 24th, 2022, the Supreme Court ruled in Dobbs versus Jackson Women's Health Organization. This was a case involving a challenge to a Mississippi ban on abortion at 15 weeks of pregnancy. This ruling overturned Roe, ending the federal constitutional right to abortion in the United States. And the decision returned the power to regulate any aspect of abortion not protected by federal law to individual states. Overnight, we saw a huge change in what was available for abortion care in the United States. There are multiple maps that are similar to this one that are floating around the internet. This one that I have right here is updated as of August 23rd, 2023. But what it's really showing you is the extreme variability in who has access to abortions throughout the United States. And this has a lot of impact. As we mentioned before, the CDC has been doing some monitoring over the last 40-something years where they are seeing what these trends are over time. Again, these numbers are for voluntary reported abortions. And so these are hard numbers that we know over the last, from 2010 to 2019, which is the last published data set. But this is anticipated to be closer to 1.1 million abortions per year. In the 48 states, in 2019, the abortion rate was anticipated to be about 11.4 abortions per 1,000 women. And there was estimates that around 20 to 30% of women would have an abortion by age 45. So what this means is that all of these women who had previously had access to more legal options, there was a huge portion of these that no longer had access. So what do you do in this situation where you don't have access to medical care for something that you anticipated you would be able to have help with? Well, there's some examples of what we saw from earlier years when that was still an option. So in 2014, there was a study that was performed that looked at patients who had already been referred to a clinic for post-abortion care. It's a small study sample. But what you see in 2014 is that while clinicians had a large source of the information for where they get discussions about abortions, a large percentage of patients did get information from websites, friends, family members, and media. Again, this is 2014, and our social media environment looks very different now than it did then. But one of the things that also is striking about this study was that in these the participants, about 50% of the participants knew that there were potentially having groups that were giving out incorrect information on abortions, yet they still were turning to these sources for information on what to do next. So we returned to an earlier age. And now you have to figure out, what do you do? What do you use? Well, there was a scoping review from 2019, which found 42 studies that were available on specific herbs to self-manage abortions. These studies usually referenced products that were prepared as teas or infusions. Major names that came out were aloe, rue, sage, black and blue cohosh, savin, myrrh, mugwort, ergot, parsley, different types of local roots depending on where you were. A lot of times these were obtained from your local herbalists, traditional healers, markets, shops, internet. And again, a lot of these studies really reference that people would turn towards their friends and family members as source for information on what to do. This scoping review also took a look at what adverse events were associated with people who used herbal concoctions. And there was a wide variability because it was a review of multiple different studies that didn't always identify things the same. But what they did find is that most of these products were associated with lower morbidity and mortality. Of the studies that reported medicinal use, between about 1.3 to 13.7% of women required antibiotics who self-managed first trimester abortions with medications, compared to about 56% of women who used intravaginal objects to complete an abortion. Additionally, when looking at women who use medicinal options such as pills or herbal products, they found that between about 0.7 to 4% of these women would actually require blood transfusions. And of the studies that reported on death, the death occurred among women who either used potions, who ingested herbs, or who inserted foreign bodies. So what does it look like now? Well, almost overnight after June, what we started to see is a lot of examples of TikToks or other social media to provide information to women out there for what do you do if this happens to you. Oftentimes, these would be ones that were almost hidden in plain sight. It would start out and it would be a normal makeup tutorial looking like thing, and then all of a sudden you would have a recipe that would flash. Or there would be comments like what are done here is, don't do this because it may cause a miscarriage. Dun, 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 dun. Do not take this many milligrams, this many tea leaves, because it may cause problems. A lot of the limitation with this is there wasn't medical support for it. There wasn't data about it. It wasn't an informed consent conversation. And so potential risks associated with a lot of these agents weren't really discussed. The goal was to give you a recipe, to give you an option, but there wasn't a lot of discussion of what could happen or what could go wrong with these. So how do we talk about the different agents that are available? Well, there's a couple different ways that we do this. Some of this, and a lot of these are very similar to what is available for the medical abortion regimens that are already in place, like mifepristone and misoprostol. When we look at progesterone receptor modulators, some of the main herbal abortifacients that we tend to see are things like pennyroyal, dongquai, mayapple, and bitter melon. I'm going to focus on pennyroyal because that's one of the most common ones that comes up in social media and also is one that has associated with a lot of significant toxicity. Pennyroyal has been used for centuries. It's historically been used as an emmenagogue and abortifacient. Its active ingredient is glucagon, though it does have some other toxic ingredients. It is a perennial bush in the mint family, has these distinctive purple flowers that almost look like a clover, but if you look closer at them, you'll see that the stalk kind of perforates through, and so you have these kind of flowers that kind of go up along with it. Other things that have been used for in the past is headaches, excessive flatulence, but this particular herb received a lot of notoriety after it was mentioned in the Nirvana song Pennyroyal Tea, in which Kurt Cobain talks about that a little bit more as well too, which kind of preempt the more discussions of it in a more modern day time. When you think of pennyroyal, I want you to think of acetaminophen or Tylenol. Pennyroyal, like acetaminophen, is hepatotoxic. It causes central lobular necrosis in the liver. And similar to acetaminophen, pennyroyal undergoes metabolism from glucagon to a more toxic metabolite, menthofuran, by your hepatic CYP enzymes. Liver damage can occur when hepatic glutathione stores are depleted, which also occurs with acetaminophen. Early signs and symptoms associated with pennyroyal toxicity include nausea, vomiting, abdominal discomfort, dizziness. You can have elevated AST and ALT that can occur within 24 hours of ingestion. This can be followed by true liver dysfunction manifested as coagulopathy, encephalopathy, renal failure, seizures, and in some cases, death due to significant exposure. The essential oil is much more concentrated and toxic than the leaves of the plant or in a tea. As little as 10 milliliters of pennyroyal oil ingestion in one case series was associated with moderate to severe hepatic toxicity, and greater than 15 milliliters has been associated with death. Treatment of pennyroyal toxicity involves supportive care, and because it's very similar to acetaminophen in kind of mechanism of action, what they found is that N-acetylcysteine can be suggested and recommended for this and can mitigate the hepatotoxicity. There's no 4-hour level. There's no lab that you're checking with this. If you have a patient who is coming in with a significant pennyroyal oil ingestion, you would just go ahead and look at starting it, and you would start it at your normal NAC dosing for just a standard acetaminophen case, and kind of following up with your regional poison center as far as when to stop it, because again, you're not basing it on an acetaminophen metabolism. You're basing it on something that you're not able to measure. The one thing that they don't have a lot of data on is it possible to potentially stop the metabolism going from glucagon to your menthofuran and stop and inhibit those CYP enzymes? There's been some talks about this as well in acetaminophen. Again, there are some potential options to use in medicine to do that and to stop the metabolism in the first place. But before doing anything else, it's really important to talk to your poison center because it's a pretty rare circumstance, and this one requires a couple of nuances. Another one that comes up is mugwort. Mugwort is not really a standalone agent, but is more commonly used in addition to other ones like pennyroyal. So when you look at teas, oftentimes mugwort is included in that as well too. Mugwort is also known as Artemisia vulgaris. It's been used in the past for menstrual pain, again as an abortifacient and depression. It's also known as Felon's herb, wild wormwood, old Uncle Henry, sailor's tobacco, mother of herbs. It's associated with the Greek goddess Artemis, which is how it gets its name, and so has a lot of relations with fertility. It's a perennial plant. It can grow up to 2 meters. The leaves, there are some variation in the leaf pattern, as you can see right here, but it tends to have these grayish white to yellowish or reddish brown flowers that are kind of arranged in these panicle areas. Tends to flower in August to September. And the big thing that's important about this is these agents right here. So some of the components include thujone. Thujone is an agent that's known throughout history and has been used as a main ingredient in absinthe liquor. Thujone and camphor can both cause seizures in research animals in a dose-dependent fashion, possibly through the effects on your GABAergic receptors. There's been cases of wormwood-induced seizures or rhabdomyolysis and acute kidney injury when somebody purchases off of the internet and consumed about 10 milliliters of the essential oil. A lot of your treatment for this is going to be supportive and focusing on things like benzodiazepines or other GABAergic agents like propofol if they're having persistent seizure activity. Another agent that comes up pretty commonly is blue cohosh. These are oxytoxic agents, are herbs that cause uterine contractions. And what this kind of means is that they're stimulating the pituitary hormone oxytocin. It's a hormone that's going to stimulate contractions during labor, usually is suppressed by the body's production of progesterone until the final stages of pregnancy. But when you're using it earlier on, you can start to have these contractions resulting in termination of the early pregnancy. When blue cohosh, it's a very pretty plant. It's very pretty blue color that you see in nature. And there's a couple of tricks to thinking about this one. In the past, it's been used as similar to for kind of women irregularity within their menstrual cycle, again, as an antispasmodic. But the thing that's kind of interesting about this one is a little bit of a tangent. So when you think blue cohosh, think about these blue flowers, but I want you to take the next step and think about something like blue camel. And when you think blue camel, think camel cigarettes. The reason for that is because the toxic ingredient that you see in blue cohosh is methylcytosine. Methylcytosine is a xenobiotic that is a nicotinic receptor agonist, structurally similar to nicotine, which you find in your tobacco plants. And when used in high doses as an abortifacient, there's a toxidrome analogous to nicotine poisoning. So what you can anticipate to find in these patients is you can see early on nausea, emesis, headache, dizziness, muscle fasciculation, seizures, and respiratory failure. Initially, after exposure to it, you'll see tachycardia, tachypnea, and hypertension. But it's a little bit of a biphasic course. And as they progress through their course, you can see more pronounced things like salivation, bronchuria, bradycardia, and sometimes some cardiovascular collapse. Additionally, beyond just the methylcytosine, you can also have other glycosides within this plant, such as calosaponin and calophyllosapinin. These have vasoconstrictive properties. And so what they can result in is they can result in vaso-occlusive syndromes. So there are some reports of women who took this to bring on labor, and the neonate was born with myocardial infarctions, congestive heart failure. One of them had a stroke, and there was no other cause that could be identified, no predilection or genetic predisposition to have any of these features. It was all felt to be related to the blue cohosh that she had been used. Unfortunately, there is no reversal agent for the nicotinic syndrome that can occur. So a lot of the management with this is going to be supportive care, fluids, vasopressors if they get to the point where they are hypotensive. The other thing too is that in the event of seizures, benzodiazepines are really the first line. If they progress on and they have more bronchuria, more bradycardia, you can consider things like atropine as well too, to kind of assisting with the clearing of secretions in the improvement of respiratory effort. Other considerations include things like intubation and mechanical ventilation. These are very unlikely to get to that point, but if you are there, that's something else to consider. Additionally, too, because it has such a large volume of distribution, this is not something you'd be able to get out with things like dialysis. And so really, if you're having somebody who's coming in who's having toxic features from their blue cohosh exposure, again, this is more discussions with your regional poison center. So there are a lot of agents on here that cause a little bit of discomfort from the toxicology community, from emergency medicine. But the one that I want to focus on right now is rue or rutagavalons. And the reason why this one I want to focus on more than some of the others is because this is the one that comes up so much in your social media. So rue has a long history. Rue is the herb of regret. It's been discussed in literature throughout time. Here in Ophelia, where she is giving the flowers away, she saves some for herself and gives them to the queen, really kind of focusing on kind of some concerns for infidelity in that time period, among other things. But it's an herb that has a lot of associations with regret. It's a shrub-like plant. It's been used in many countries, including England, France, and Brazil, to stimulate menstruation and induce abortion. When they looked at this from a South American poison center, which is where it had a high prevalence, there was a higher incidence of hepatic, renal, and hematologic arrangements among patients who had used rue either as a single agent or mixed with other herbal xenobiotics for self-managed abortions. Toxicity with large ingestions has been severe. There's been documented cases of multi-organ failure causing significant electrolyte derangements, as well as hemodynamic instability that required excessive and aggressive resuscitation needs. A lot of this end organ toxicity is thought to be secondary to the chlepsin, which is found in the plant. They don't really know the specific mechanism of the toxicity, but they found that of the plants that are exposed, this is one that has a high risk associated with it. And of that particular study from the South American Poison Centers, of the patients who had a maternal death associated with exposures, it was primarily with rue if they did go on to have a death. The other thing that's kind of interesting about this plant is that it also has um, this sorolin, which is a furanochromine that intercalates DNA of the dermal cells, leading to formation of photoetics. So in English, what this means is that these patients can have photodermatitis, especially of light exposed skin. When people get sick from this, what we tend to see, nausea, vomiting, abdominal pain, they can progress to hepatotoxicity and nephrotoxicity. And as mentioned, they can go on to multi-organ failure as well too. But they can have this phytodermatitis as well. For most of this, again, it's going to be management of their symptoms, treating patients who have hypovolemia from significant GI losses as well. And then specifically, the patients that have some of this nephrotoxicity, you can consider renal replacement therapy. It's not going to pull out the agent. It is not going to eliminate that from it, but it can potentially help assist with the management of the renal toxicity. And then finally, the dermatitis that can be associated with this. For most cases, this can be managed with topical steroids, but in really severe manifestations, sometimes you have to consult a surgeon. It just kind of gives you an idea of the degree of toxicity that is possible with this plant. The last one I want to talk about is gossypol. And gossypol is not one that's mentioned as much in the literature, but I think it deserves just a special pause because it's one that's been used by both men and women for similar things. So interestingly enough, in the 1950s, what they found are there were these areas in rural China where there was really low birth rates. And there was actually one little community where there was no births for 10 years. And what they did is they looked a little bit closer and they identified that they were using, during that time period, they had transitioned to use raw cottonseed oil. And with that, there was a significant change in the sperm motility and spermatogenesis in those males. The other thing that was really exciting about it in the time was that if you took that out of their diet, these patients would have full reversal and go back to normal sperm motility and spermatogenesis within about 3 to 6 months. And so this was a really exciting idea during that time period of something that males could do to also kind of manage the reproductive health. So they started to do some research on this. And as I mentioned before, they were extremely excited. In 1972, they had a multi-center study that involved 14 centers and 8,806 volunteers to really take a look at the efficacy and side effects associated with it. This chart that I'm showing you right here is just a small subset of kind of a bigger sample that was taking place. So this one is not looking at that 8,806 patients. But what they found is that if you were using 50 milligrams per week, it had about a 99.1% efficacy rate to decrease your sperm count to the point where you would not expect to have reproductive capabilities. So what they did is they looked at this a little bit closer and they took that dosing, the 50 milligrams per week, and they followed it on to see, okay, well, if we use this, what is the efficacy associated with it? And they found that when men were using this, their partners, when they were followed for 6 months and 12 months, all of these were within reproductive age. All of these were viewed as not having any reason to not reproduce. But none of these women, for the partners of the men, got pregnant. They did, and the other thing that was really important to this too, is that none of the men were lost to follow-up as well. They were followed to completion. What they did find initially is they found that there was some fatigue. It was more pronounced as they went along. Maybe some appetite changes, maybe a little bit of other libido things, but nothing really big. And so they got really, again, excited, started to move on to more clinical trials associated with it. But what came out with later studies was that there was potential to have other side effects that weren't happening at a high rate, but potentially had some big mortality risks and morbidity risks. as discussed earlier, what they found is that the most common side effects were nausea, appetite changes, gastric discomfort. People would describe some muscle weakness would be overall okay. But then what they found is that there was this effect on potassium. And so these patients would come in and they would have lower potassium levels. And so they tried to kind of mitigate that with kind of repleting the potassium. But these patients would have episodes of hypokalemic paralysis. Now, it happened in about 1% of the patients who had this, but it was pretty severe. And so, based on this side effect, they really stopped doing a lot of the research and stopped doing a lot of the clinical trials on it. Again, some of the considerations with having your potassium concentration that low was the potential for cardiac dysrhythmias as well too. This was extremely low, was not even as high as the hypokalemic paralysis, but kind of all in the setting of knowing that those things could happen, it really kind of shifted them away from using this product. Self-managed abortion methods with most herbal recipes are unlikely to cause major toxicity. However, there are agents such as pennyroyal, blue cohosh, rue, quinine, amongst others that have notable toxicities. And if you have somebody who's coming in with those, it's really going to benefit to talk with your poison center to kind of get an understanding of what else to consider and what else to use. The other thing that doesn't come up with a lot of these is what happens if you take these agents and then the pregnancy persists? Because there is some potential for teratogenicity associated with these agents as well too. And so it's not just the immediate event of what the patient looks like right now, it's if that patient continues to carry the pregnancy, what do you do next? There is unfortunately so much misinformation and disinformation out there that it is really hard for the current population who is of reproductive age to identify what's safe to use and what's not safe to use, especially if you are in a state where there's a lot of limitations to your access to abortion. There's been a couple different studies that have looked at social media and how they've continued to spread that misinformation and disinformation. There was a major social media site that accepted between 115,000 to 150,000 for multiple ads that kind of promoted this abortion reversal pill, which was found to be extremely dangerous, actually resulted in significant hemorrhaging and mortality associated with it. And so what this really just aims to show is there is just so much information that is constantly being available without any of that background. And in a day when you can't turn and ask your healthcare provider what to do, what do I take, how much do I take, and in an age where you no longer have, the midwife who's has had for years used this medicine, but going back and back and back, and can give you more ideas on how to do this, there is a lot of potential toxicities that can be associated with these. I think a lot of this is being open with your patients about what they're using, talking with them about some of the risks associated with that, making sure that they really have the information that they need. Because regardless of what side you believe, regardless of what your personal thoughts are on this matter, the big thing that's really important is a huge percentage of our population in the United States is of reproductive age. And so if they feel that they are stuck, if they feel that they are in a situation where they don't have much access, this is something that they are potentially reaching for to try and manage their situation. And so really having those open dialogues and open conversation is huge to kind of help make sure that they are safe and that they are healthy. And then kind of whatever happens next with the pregnancy is in the safest manner as well too. Remember, none of this is a substitute for your medical advice. Stay informed, know your risks. And again, if at any point you need help, wherever your poison center is, they're open 24/7, just waiting for your phone call. We're at 1-800-222-1222. Okay, with that, I will reach back to you, Megan. Any questions?
Great. Thank you, Dr. Kaiser. So there was a question about the reversal pill and a comment saying that there are a whole bunch of billboards in Spokane County about it. I don't know if you want to speak any more to it. The question was asking if it was misinformation and is it endangering women or people with uteruses?
Yeah, so this was a huge deal. The study that I was referencing that identifies how much money was gained from this, I think was 2021. The problem with this is this was actually looked at in clinical trials and was actually taken off because of the risk of hemorrhaging. And so the biggest concern with a lot of these agents is it was spread on social media, and the social media information just wasn't, doesn't have the fact check, doesn't have the scientific information, and potentially put a lot of these women at risk. What they continue to see after that as well too is there was a lot of searches on different search engines, which made it look like there was that this was more factual than it really was. And they kind of disguised the way that they commented to make it show that it was more neutral or helpful, but it continued to kind of spread this misinformation. And so that's always the concern when you don't have the right information in front of you is, maybe you don't have a bad outcome with it, but that doesn't mean that the person next to you who you're giving this information to as well too doesn't have a bad outcome. And these were ones that were known to have bad results from them.
So there's another question about vitamin C being a method back in the 1990s. Is this a currently used method?
So it is one that comes up. It's not technically an herb, so we didn't include it here, but there are multiple different sites that talk about the use of vitamin C as well. Again, with all of these, when you're using them outside of kind of normal uses, there is potential for complications with this as well too. There is some studies that have looked at its efficacy that really range, and it depends on kind of what dose you're using, how you're using it, and when you're using it. A lot of these agents that we're describing here, when they are efficacious, are more efficacious early on in pregnancy, which is similar to some of the medical uses as well too with the pills. They're more efficacious early on than they are later.
So the last question here is, in layman's terms, is there a formula to apply with each of these plants? Is dosage dependent on weight and height? Is there a formula for milligrams or milliliters that can be calculated for people so as to avoid poisoning themselves?
Um, so for the most part, oils are going to be more potent than teas or infusions, but potency doesn't always mean that it's going to be better, because sometimes if it's more potent, that can also mean that you're going to have more potential for toxicity as well. And a lot of the people who got in trouble, it's because they used oils over the teas or infusions. There isn't a recipe that you can say for each of these, this is the mg per kg. And part of that's just because their mechanism of action is so different with each of these, where, what you are looking at with your blue cohosh is very different than what you are looking at with your rue, than what you're looking at with like your cinchona bark. And so it's really kind of agent dependent. There are more, naturopathic and holistic literature that kind of goes over what's been used in the past. Again, while most of these don't have really severe mortality, it's possible, and we have to just be careful when you are assessing it and really be agent specific with what you're looking at. And I would recommend that you do this in concert with your medical professional, just because there's things that can go wrong. And at least if somebody knows what you're using, they know what to do to help you in the future, or can talk with you about what are potential complications. I think the biggest thing that nobody talks about too is, again, if you take this and everything doesn't go as planned and you still are pregnant at the end of it, what's going to happen to that developing pregnancy? And in some cases, there's not bad side effects from it, but in other cases, there have been fetal abnormalities that have occurred because of these exposures in utero.
So final question here, for people who didn't get the chance to watch this lecture, what is your one takeaway that you want to share?
I think this is like all of these different lectures where you really have to be open with having these conversations. Because if you do not provide an environment where you are open to have the conversation, you're never going to know what your patients are using. The other thing that's really hard about herbs is that a lot of times people don't consider these medicines. So when they come into the hospital and they're sick, or when they're calling because something's wrong, they don't always recognize that that could be the cause of it, and they don't always tell you, especially in a situation where you're worried that there is going to be legal ramifications from using this. There can be very secretive components to this. And so I think the biggest thing that I would recommend is finding a way to gain that trust so you can have that conversation. Um, you know, talking with your provider when you do use these, because your disclosure of this can make a difference. We had a case of pennyroyal toxicity where they came in 2 different times. And one time it was apparent, one time it wasn't. The time that it was apparent, they got treated with acetylcysteine. They did fine. The time that it wasn't as apparent, didn't get treated, and went on to have significant hepatotoxicity associated with it. And so there are times where antidotes can make the difference. There are times where medical interventions can make the difference between maternal morbidity and mortality. And so finding a way to have those open conversations and being a provider that enables a conversation to really disclose that information makes a big difference for not only your safety, but also to kind of continuing that conversation to make sure you have access to whatever care you need moving forward.
Thank you, Dr. Kaiser. And I just want to put the plug in one more time, for individuals who maybe live in areas that might not be as open to discussing this, please call your regional poison center. We are here to help you. We are confidential. This is what we're here for. So, all right. Well, thank you so much, everyone. We're a minute over. We'll let you head to your next session. Dr. Kaiser, thank you again so much. This was such a comprehensive lecture. You covered so much history and modern information as well. So we really appreciate it.
Well, thank you for everybody for your time. I appreciate you guys watching.
Thank you. Bye.
Bye.